Muskoka District Health Unit, here to provide the COVID-19 update for Simcoe, Muskoka. As of today, we have 468 cases, up from 460 yesterday, so an additional 8 cases. We've actually continued to see an ongoing decline in the weekly cases over the past really 4 weeks now, which is certainly very good news. So this week so far, we've had 27 cases. The week isn't over, so that's not going to be the total count for the week. Compared with 40 cases the week before this week, last week, 44 cases the week before that, and 74 cases the week before that. So definitely a downward trend. Of our 8 cases that we have today, none of them are associated with long-term care facility outbreaks. So they're all cases that have occurred in the community. 5 are male, 3 are female. Their ages range from under 10 to in their 80s. All are at home self-isolating. None of them are in the hospital. 4 of them were acquired in the community, and 3 were close contacts of another known case, and 1 is under investigation. And all of them have occurred in communities in Simcoe County. We've also had 5 individuals newly recovered. So that makes a total of 373 people who've recovered. That's 80% of all of our cases. And that percentage is continuing to go up over time. For example, on May 22nd, only 74% of our cases had been recovered. We presently have 8 people in hospital. That's up by 1. It had been 7 since I last reported. We've had no additional deaths, so a total of 36 deaths. And we have no outbreaks in long-term care facilities or retirement homes or group homes. So we had 3 outbreaks when I was last speaking with you, and they've come to an end. That's Owen Hill Care Community, Collingwood Nursing Home, and Bayview Retirement Home. So just looking back over our data and comparing months, April was a month in which we had the largest onset of cases, new cases. So we had 227 cases confirmed in that month, and 59 of those were outbreak related, in comparison with May, where so far we've had a total of 180 reported cases. So that's a 21% decrease. Once again, pointing out how we're definitely at this point on a downward slope when it comes to the pandemic and its impact in our community. And I always point out that this success is due to our collective efforts together, how we've all worked together to flatten the curve through our physical distancing, our hand washing, keeping a setback of 2 meters from other people when you go out, being careful about going out. And I always like to point out that going out is good for people. It's just that when you do so, you need to exercise these precautions. And if you develop any symptoms, you need to put yourself into isolation and seek assessment and testing, which allows us then to follow up with people who are found with testing to be cases, so that they can be kept in self-isolation, and then we can follow up with their contacts and have them go into self-isolation, all of which helps to flatten the curve and keep us on that downward trajectory of cases. We do know from our modeling
Hi, and good afternoon.
Good afternoon.
Curious, Dr. Gardner, the 45 to 64 age categories seem to have by far the most number of cases. Do you have any suspicions as to why that might be the case?
It's remained that way the entire time we've been following this. It's probably related to demographics and the average age groups, the largest grouping of, what is the age span that is largest in our population to begin with. Another way of looking at this is if you analyze it by the proportion of the population or the size of that population, you can get a rate instead. So if you look at one of the figures that we have here does that, the COVID-19 age-specific incidence, case hospitalization, case fatality rates. So it expresses it as a rate, and instead what you see is that age group range actually doesn't have the highest incidence. The highest incidence is actually those 80 and above. That just takes into account that there is a much smaller population of people in the community that are 80 and above, and so you take the total number of cases that we have of those 80 and above and you divide it by how many people in the community are that age, you get that rate, and that gives you a better sense as to the risk of getting this infection for any one individual in those age ranges. And so when you do that, you see that the 35 to 44 age grouping no longer really predominates much over the others. Is that helpful to you?
Yeah, and the other question I just thought is, seen today, this week rather, stories on the employees testing positive, employees in York region, and one in Bradford testing positive as well. At some point, are we going to need to step back from our reopening plan?
So that's certainly a good question, and that's part of the reason why I indicated that we need to look closely at the work environment and to track our data in terms of cases acquired through the work environment. Because we're now opening up the work environment, that's a new front in which transmission could happen. That's where we need to be very careful as we open up. I'm not aware yet of any cases that have occurred in the work environment apart from healthcare environments where we've had cases transmitted in outbreaks in the healthcare environment, hospitals or long-term care facilities out of our district, but people living here, or in our district and people living here. But the potential is clearly there for this to be happening in other work environments, and I have heard that there has been such transmission elsewhere in larger urban centers. Therefore, we need to be watching it, we need to be careful about it, we need to be working with those businesses, those manufacturing centers, to put in place as much precaution as we can and to facilitate screening, of course, and testing. In particular, those who develop symptoms, absolutely, we want to be facilitating that. And we want to be facilitating that we track and report in our numbers cases that are acquired through their work. Of course, you're going to get people who work in those environments and contract it elsewhere in the community. That is clearly still a possibility, and we would need to make that distinction in our reporting. But back to your point, we need to be monitoring for the potential for this.
Thank you very much. Have a great one.
You too.
All right, Dawn McNeil from ISM. Did you have a question for us, Dawn? All right, we're going to move on to Doug Cross from Muskoka region.
Hello. The first question I have is in relation to your tracking, trace tracking. Have you ever go outside your own office to use other resources? I know the federal government had put staff 10 people on standby, that type of thing. and provincial governments have been helping with that as well, and you've been able to do it in-house.
So I don't think I quite heard all of your question. I'll just rephrase it and see if I got it right. You were talking about the potential to bring in personnel from other agencies, maybe the federal government. I've read of that in Ottawa, for example, where federal employees have now been assisting in case and contact management with Ottawa Public Health, I believe. And you're asking whether or not we are doing the same or could be doing the same. Did I get that right?
Yes, correct. I just wanted to know if there was such a level of reporting to be done that you might need outside help.
Certainly we need to make sure we've got the resources to do our jobs well. And we are actually going through hiring right now in order to bring people in who can help us with our case and contact management and with our phone intake. We want to be able to what we call repatriate staff who normally are doing other work, other public health work, but had been put to the cause of responding to COVID-19. We want to be allow at least some of those to be able to go back to their normal line of work. And this is to allow us to be able to get out there and inspect and enforce those new work environments, business environments, to advise them about COVID-19 and how to avoid transmission happening in those venues. And we also need to be able to put back in place a lot of our other routine programming so that we avoid other problems like outbreaks of vaccine preventable diseases or food or water-borne outbreaks, or other issues as well. Child reproductive health is an important topic. Tobacco control is an important topic. Responding to the opioid crisis is an important topic. So we want to be able to return some of our staff to that kind of work. And so we are bringing in people to help enable that. We're also finding that with the reduction of cases right now, that's helping us to free up our resources in and of itself to be able to put people back to those other jobs. So here in Simcoe, Muskoka, I think we're doing okay with that approach. We need to be mindful that that could change. If you end up with a surge of cases, then we will have to look again at what we do to make sure we've got our resources in place and we're putting them where they're needed. And if we need to redeploy some staff back again to responding to COVID directly, then we would do so. We are fortunate in that our caseload, the incidence of COVID-19 in Simcoe, Muskoka has always been at about half the rate of the province as a whole and maybe a third of the rate of the Greater Toronto area. So that has allowed us to be less severely impacted on with the workload, the resources that we would need. We've been able to manage with the resources that we have. We've certainly had a lot of staff who've done overtime and been deployed to work at odd hours, weekends and evenings. So that's had an impact on us, but we've been able to get by to date mostly with the resources that we have. So I don't think we're going to need to seek that kind of solution, a secondment from another agency such as the federal government. I don't think we'll have to do that.
All right, terrific. And as we go week after week with this, is it helpful to be sort of quoting the overall number of cases that are in the area, or will it start to be more helpful to just talk about active cases? Because that number is becoming a lot smaller. What's your feeling on the reporting structure?
Well, very good point, right? As you look at an epidemic, there's a tendency to look at the total case count, but it can only go up, right? And if one only looked at that alone, it would we gave some attention today to the number that had recovered. I think was an indicator of trying to put it in picture and make it clear that we're headed very much in the right direction at the moment. So indeed, you've got to look at a few indicators and not just the total number of cases to date.
All right, terrific. Well, it's been great to see the numbers dropping. So,
Mm-hmm.
good stuff.
Thank you.
Thanks, Doug. We'll go on to Nathan Schubert from Moose FM.
Good afternoon, Dr. Gardner. Just a quick question for you. Now, with these numbers going down, are you worried that people are going to be like, oh, perfect, numbers going down, I might as well start going out again?
Yeah, well, that's
Is there any concern with that?
Yeah, that's always the danger, right? It's down, but it's not finished. And while the virus is circulating in the community, and we know that the great majority of people are not going to be immune to this, it's a very small proportion of our population that's become infected. Therefore, everybody else is entirely vulnerable to this. And in fact, we're not sure how much immunity even those who've recovered will have, right? It will come back. We know from our modeling, if we're not careful, it will come back. So we need to keep emphasizing that. And as we open up venues and businesses and public settings, the potential for that increases. And so all the more so we need to put out the message. And I can see that good news can be a danger in itself because it can lead to complacency.
That's it for me. Thank you very much.
You're welcome.
Thank you, Nathan. We'll move on to James Buller from Coach Call. You still with us, James? Okay. Mandy from Webster from Rogers.
Sorry there, sorry. No questions from me today.
Oh,
Just lots of good
all
news
right.
today, Dr. Gardner. Thank you.
Thank you.
Did anyone join us after we started who we haven't recorded their name? Well, that looks like it's it then, Dr. Gardner. Thank you very much. Our next briefing is Tuesday at 12:30 p.m.
Thank you. Goodbye, everybody.